Thank you very much. It's a big pleasure to be here. As you know, in stroke patients, the choice of a therapeutic is not only based on time. Of course, time is important, but it's also based on imaging. And the therapeutic target is the penumbra in ischemic stroke. And this zone can progress to infarction without treatment or can recover with effective treatment. And it's possible to, with imaging, one of the aim of imaging is to determine the penumbra and the necrosis. And to evaluate the penumbra and the necrosis, we can use CT or MR. Using CT, we use non-contrast CT and perfusion CT, and with MRI, we use diffusion and perfusion. But the evaluation of the necrosis of the infarct core and the penumbra is not perfect. And recent advance with MRI post-processing techniques allows MR oxygen metabolism maps like oxygen extraction fraction and CMRO₂. Why am I talking about those two maps? Because those two maps are the gold standard using PET for penumbra evaluation. Penumbra, the gold standard, in vivo gold standard penumbra evaluation is with OEF, CMRO₂, and CBF. So that's why I will talk about those parameters. So what are the potential application of those maps? I think the first application, I will give you some example, it's maybe a better understanding of the physiopathology of stroke. And I will talk a little about the role of collateral circulation, and I will talk also about the brush sign. I will give more details about this. But I think what is very important, I really believe that those maps may really improve patient care by assessing tissue viability in the diffusion and also in the perfusion. So what about the penumbra? Here we've got the example of two patients with proximal occlusion. In this patient, you can see more than 6 hours after the occlusion, the lesion is small, while in this young patient, 2 hours after the occlusion, the lesion is huge. What are the differences between those two patients? The collaterals. Therefore, collaterals are very important. So the role of collateral circulation is to maintain blood flow to the tissue, and it will slow down the progression of tissue from penumbra to infarct. Therefore, it may increase the therapeutic time window and will decrease the final stroke volume and the hemorrhagic transformation. So the aim of this first study, I will summarize, was to evaluate the relationship between collateral circulation and oxygen maps in patients undergoing mechanical thrombectomy with two groups, one group with good collateral and one group with bad collateral. This was the work of the MD thesis of Paul Patural. So in this study, we show that the main factor associated with good collateral were, of course, the diffusion volume. If you have good collateral, the diffusion volume is small. But the other parameter, main parameter, was the relative change in CMRO₂ within the ischemic penumbra. And these were the two main parameters associated with good collateral. And this is illustrated in this case with two patients, one with good collaterals and one with poor collaterals assessed by DSA. And as you can see, CMRO₂ is preserved within the ischemic penumbra in patients with good collateral, but reduced in patients with poor collateral, as you can see here. In good collateral, the CMRO₂ here is preserved in the perfusion defect, while in poor collateral, you can see a decrease in CMRO₂. So CMRO₂ is very useful. What about the brush sign? Here is the brush sign, as you can see here. What does it mean? The brush sign, which is visible on T2 star or susceptibility sequences, is the abnormal visualization of medullary and subependymal veins. As you can see here, those small dark here, you can see the vein. And it's important where we are evaluating patients in stroke because it's associated with more hemorrhagic transformation after thrombolysis and also a poor functional prognosis and a larger final infarct. So the aim of this other study was to assess the oxygen metabolic abnormality occurring in stroke patients with brush sign treated by thrombectomy, and this was the MD thesis of Guillaume Criton, which was published last year. And in this study, we show that the brush sign is associated with a higher decrease in CMRO₂ within the ischemic penumbra, as you can see here. So in this patient, we can see the brush sign, and we can see a high decrease in CMRO₂ in the perfusion defect, while here there's no brush sign, and the CMRO₂ was preserved. And this is confirmed by this graph, where we can see that the relative change in CMRO₂ within the penumbra was high in the penumbra here, and it was not significant within the infarct core. So, but I think more important about those maps is about tissue viability, because it may change the patient care. The definition of infarct core using MRI is diffusion, but diffusion does not represent the true infarct core. A part of diffusion is reversible, as you can see here, with proximal occlusion at admission, and after thrombectomy, you can see the reversibility of the diffusion abnormality. And in this study published by Alexandre Banissat, that you know, we show that an increase in oxygen extraction fraction within the diffusion lesion is associated with diffusion reversibility following successful thrombectomy. As you can see here on this graph, when you have an increase in the pixel, increase OEF in the diffusion, you will have if we look at the flare a week after, you will have a decrease in lesion side. While if the OEF is not increased, the lesion will be stable. And this is illustrated in this example. Here you've got the diffusion, and you can see an increase of OEF in the diffusion, and after thrombectomy at follow-up, you can see a reversibility of diffusion abnormality. While in this other example, you can see here the diffusion, here the OEF. You can see here an increase of the OEF, but it's outside the diffusion abnormality. It's an increase of OEF inside the perfusion defect. It's normal. But you can see that in the diffusion abnormality, the OEF is not increased. And at follow-up, you can see stability of diffusion lesion. What about, here we look about the diffusion, but what about the perfusion-diffusion mismatch zone, about the penumbra? Despite successful thrombectomy, most patients experience infarct growth, as you can see here. And in this study, we show that when CMRO₂ is low in the penumbra, it was likely to evolve to infarction. And relative CMRO₂ was the strongest predictor of infarction in the penumbra compared to other parameters such as CBV, CBF, and OEF. OEF, in fact, was not a very good parameter in this case because we believe that OEF, it's always increase in all patients. In the penumbra, in the perfusion defect, OEF is always increased, and CMRO₂ is a better parameter. So we believe that collapse of CMRO₂ may precede diffusion abnormality in some instance. So in conclusion, and what about the perspective? Using those MR oxygen metabolics map in stroke patient. Of course, I think the most important is the improved assessment of tissue viability. And we believe that the evaluation of metabolic penumbra using the same parameters as PET, using OEF and CMRO₂, the true definition of the penumbra using PETs is a normal CMRO₂, quite normal CMRO₂, an increased OEF, and a decreased CBF. We believe maybe that this approach is maybe better than conventional approach, either with CT perfusion, but also with MR. And here we've got an example using CT. In Lyon, in France, we are doing a lot of MR, but now we are also doing a lot of CT. And here an example of using CT with a CMRO₂ with a decrease of 30%, for the infarct core, the evaluation using CMRO₂ and using CBF, you can see that the prediction is much better with CMRO₂ than CBF. So for sure, I think metabolic penumbra is maybe the future of this technique, and Alexandre Banissade will give you some more information during his workshop tomorrow. But of course, what is missing is the validation of the technique. We are talking about OEF, CMRO₂, and comparing this to PET. But is it the true OEF and CMRO₂ map? So I think it's also important to do a validation study and to compare those maps to the PET maps. Okay, thank you.
Thank you very much for sharing these exciting data. There are questions from the audience. Yes, I think Dr. Nicolini has a question in the... You can borrow mine.
Thank you. Thank you for this presentation, really interesting. I had two questions. The first one for OEF. How do you define the increase of OEF? Do you have a cutoff or is just visual assessment? And then another question is that if you have some clinical data, especially in large core, you showed actually a large core with finally a small lesion at 24 hours. So maybe that's why trials were positive, I don't know.
In the study of Alexandre, first we looked, it was visually. It was visually, and because it's very easy to see the increase of OEF on the diffusion maps. So it was visually, and after we found a cutoff. But first, when we look at the image, it was evidence when we look at the flare and the OEF map, when visually we saw an increase in OEF, there was always a reversibility of the lesion. And after, of course, we did quantitative analysis and we found a cutoff, but I don't remember exactly the cutoff. And with diffusion reversibility, it works well with OEF, but it works also, of course, with CMRO₂. But with CMRO₂, visually, I think it's more difficult to see in the diffusion a real decrease of CMRO₂, because you've got a lot of decrease in CMRO₂, while an increase of OEF in the diffusion is very easy to see. But of course, OEF and CMRO₂ will work on diffusion reversibility. And about large core, of course, it works in large core, I think it's important, but it works also in small core infarct. I think the diffusion reversibility will work both.
Other questions? So I'll rephrase my earlier question, sort of, if you could choose a few, so not only one, but a few parameters that, should guide our future management of stroke patients, which one would you choose?
I will use OEF CMRO₂ for the penumbra evaluation. And I think maybe the next step, maybe OEF and CMRO₂, with CBF, of course, because, or Tmax, will be the new maps to evaluate stroke patients, because we really believe that the evaluation of the core and the penumbra is better with those techniques. And I think this is very important because, as you know, now there's a tendency not to use perfusion for treatment of patients. And I think maybe one of the reasons, of course, it's a little more time, but also one of the reasons is the evaluation of the core and the penumbra is not perfect with the technique that we have. And maybe with those techniques, it will be better. This is my guess. And this is Alexandre's work.
Thank you so much.